Prabakaran. Dr. Prabakaran. Prabakaran. Start பண்ணலாமா?
Start பண்ணுங்க sir.
Right. So I welcome all the participants to the third day of the international webinar on recent developments in cancer research and therapy. And sorry for the delay because we have encountered a few technical issues from our side. And now we have rectified it. So before we commence, let me ask as a co-organizing secretary, kindly bear with us. So let me take this opportunity to thank the management people, the principal, and most respected head of the department for permitting us to organize a great program on this innovation field. And we as an organizing team thank the management people and principal for providing all the infrastructure facilities for doing live relay of the program. And so now I invite Dr. T. Selvarathinam sir, Assistant Professor, Department of Biotechnology, to propose welcome address. And I also request him to introduce today's resource person. Please, sir.
Yes, thank you, sir, Dr. Samuel, sir.
Thank you.
Hello, everyone, and welcome back to today's session hosted by the Department of Biotechnology, Ayya Nadar Janaki College, Sivakasi. Your active participation is important throughout the session. I want to thank our head of the department and co-organization secretary to give me an opportunity to welcome you all. I would like to welcome our most respected principal, Dr. Sri Ashok, and the head of the department, Dr. M.K. Rajan, to this third day sessions. Welcome you, sir. I also welcome our visiting faculty, Dr. D.S. Prabakaran, sir, Department of Radiation Oncology, Jeongbuk National University, Korea. Welcome you, sir. I extend my warm welcome to today's resource person, Dr. Ashish Tyagi, postdoctoral fellow, University of Louisville, to deliver his research topic on muscle invasive bladder cancer. Welcome you, sir. I also welcome faculties, scholars, students of these institutions and other academics. Now I would like to introduce today's presenter, Dr. Ashish Tyagi, postdoctoral research fellow, University of Louisville. Dr. Tyagi is in Louisville and works with hemo-oncology. He is a member of Society for Basic Urologic Research, American Association of Cancer Research, and Probiotic Association of India. And Dr. Tyagi is also an editorial board member in various journals. He published his original research in journals with high impact factors. He received so many awards with respect to cancer research. Dr. Tyagi served in various capacities like postdoctoral research associate, senior research scientist, and research associate. Dr. Tyagi registered his PhD work at HNB Garhwal University, Uttarakhand, and for his work, awarded for his work on transgenic cattle. I ensure the webinar will be useful for all us, and the next few hours will be fruitful for every one of you. With this brief introduction, I hand over to the co-organizing secretary, Dr. Samuel, for the next agenda. Thank you, Dr. Samuel.
Thank you, Dr. Selvarathinam, sir. Thank you, Dr. Selvarathinam, sir, for your wonderful welcome address. And this is the time to share our time with the resource person of today's event, Dr. Ashish Tyagi. So once again, on behalf of the organizing team, I welcome you, sir, and we thank you for sparing your valuable time with us to share your ideas in the field of cancer research. So, sir, we request you to present your ideas, please, sir.
Thank you, sir. Good morning, head of the department and respected principal and all the faculties and fellow students. And thank you very much for inviting me for the talk. And the topic of my talk would be treatment strategies for muscle invasive bladder cancer. So, bladder cancer is one of the primary causes of cancer death in US. In terms of the economic burden it causes, because there is a chance of recurrence, and the management of bladder cancer is economically very high. So bladder cancer is one of the primary causes of most economic burden in US and worldwide. In 2020 itself, approximately more than 80,000 people have bladder cancer new cases, and more than 2,000 people have died. So before I start elucidating various treatment strategies and the corresponding research that is undergoing at our university as well as worldwide generally, it is important that we have a brief overview of what bladder cancer is and what are the stages, and then we will go on to the treatment options, which include surgery, radiation, and chemotherapy. Next slide. So the stages. So this presentation would first give an overview of bladder cancer stages and the current treatment strategies, followed with the need for treatment options, new treatment options, and then I'll provide an overview of the research in the field of bladder cancer. So as you can see on this slide, are you able to see the stages and diagnosis?
Samuel, sir?
Can you see the... Yes, sir.
Yeah. Are you sharing the slide number 3, right?
Yes.
Second. Samuel,
3.
sir, please change the slide to 3. It's in second now. Oh, okay.
Yes.
Thank you.
So at the stages of diagnosis, there are 3 broad categories. So most of the bladder cancer is superficial. That includes TA stage, T1 and T2A. As you can see in this picture, the innermost layer, the first layer in bladder is the epithelial layer, and it is surrounded by the mucosa. The next layer is lamina propria, and that is followed by the muscular layer. And muscular layer is divided into superficial muscle, which is towards the epithelium, and then there is a deep muscle. This is followed by a fatty layer, and then peritoneum, and then the surrounding organs. So most of the cancer, bladder cancer, is in the superficial stage. So that is to the epithelium, and that is considered as the TA stage. T1 is also in the epithelium, but it metastasized, it invades the lamina propria. The other stages affects the muscle in the bladder, and these are T2A to T3B. These are all muscle invasive bladder cancers. After these, the bladder cancer metastasizes to other organs, distant sites, and that is the T4 stage. But as I said, most of the cancer is 75 to 80% is superficial, and rest is muscle invasive, and 5% only goes to metastatic stage. So next slide. So for early stage bladder cancer, which I explained in the earlier figure, the TA and T2B, for early stage bladder cancer, there is transurethral resection of the bladder, which is followed by intravesical chemotherapy. This is for the treatment of early stage bladder cancer. And there is immunotherapy also in the form of BCG. BCG, as you know, is Bacillus calmette-guerin. And interestingly, it was the first immunotherapeutic treatment for bladder cancer, which was approved by FDA in 1970s. And since then, BCG has been the standard therapy for treating high-risk non-muscle invasive bladder cancer to avoid its recurrence and progression. And it is applied after the transurethral resection of the tumor, that is TUR, TUR. If the patient responds appropriately, uh, then every 3 months to 1 to 3 years, this therapy is undertaken to reach the optimum effect and to avoid the recurrence. For MIBC though, when the cancer invades to muscle, as I explained in my earlier picture, in muscle invasive bladder cancer, partial cystectomy after chemotherapy has been provided and radiation therapy can also be done. And it is based on how advanced the cancer has progressed. Next slide. As you can see here, these are the examples of how bladder cancer is treated in early stages as well as in muscle invasive bladder cancer. In early stages, the first step would be the cytoscopy to see where the tumor is, where the cancer cells are. And if the tumor has not progressed to muscle and it is still in TA stage or T1A stage, where it is just in the epithelial or lamina propria, there is transurethral resections followed by chemotherapy. And chemotherapy is given at the site of the cancer. So this is, as I told you, that this is BCG and also MITO. These are the chemotherapeutic options which are given by after transurethral resection. Whereas in muscle invasive bladder cancer, total cystectomy or partial cystectomy is done. So in surgery cases, there is 50% chances of 5-year survival. It increases with the conservation strategies, that is total cystectomy and bladder preservation strategies come into play, or partial cystectomy. The chances increase to 68%, but most of the patients deny having total cystectomy because of life expectancy issues, and quality of life decreases drastically after that. So in that case, induction, chemosurgery, and also radiation therapy comes into play. Next slide. So for high risk cancer, as I told you that some of the patients refuse total cystectomy, the radiation therapy along with chemotherapy can be given. So post-operative radiation for high risk cancer can be done. And this radiation therapy is with the chemotherapy after the cystectomy. Before the cystectomy, during the surgery, chemotherapy is given along with the radiation to avoid this total cystectomy. And radiation alone or with chemotherapy for patients who are not candidates for major surgery, who sometimes patients deny, or sometimes it is too risky to do total cystectomy because of comorbidities. So for those, radiation and chemotherapy is used. Next slide. So as you can see here, the chemotherapy is cisplatin-based chemotherapy in muscle invasive bladder cancer. And when chemo and radiation are combined, they have significantly less chance of relapse. As you can see here, in chemo and radiation, only 29% chances of relapse, whereas in radiation alone, it was 52% chances of relapse. Also, 5-year survival with radiation for muscle invasive bladder cancer. In alone cases, it is only 39%, whereas it increases for 51%. So chemotherapy along with radiation therapy is a good way to go to treat muscle invasive bladder cancer. But there are problems when we go to cisplatin-based or platinum-based chemotherapies because of several side effects. Next slide. So in non-muscle invasive bladder cancer, that is good prognosis, although it is associated with frequent recurrence. This cisplatin-based chemotherapy with radical cystectomy at pelvic node dissection is the gold standard for treatment right now. So cisplatin-based regimens like MVAC, GC, PGC, which includes combination of doxorubicin, vinblastine, cisplatin, and other drugs like gemcitabine and paclitaxel. These combinations are given with the combination of radiotherapy so that to manage the muscle invasive bladder cancer. But as I told you that there are acute side effects associated with cisplatin, and the prognosis of patient with advanced bladder cancer is so poor that when the bladder cancer is already advanced, the diagnosis takes place in the last stages. So in these chemotherapies with the comorbidities, these acute side effects are dangerous. So that's why the current non-surgical conventional treatments, such as these intravesical pharmacotherapies and systemic chemotherapies, they often fail to completely prevent the recurrence of superficial bladder tumors, muscle invasive bladder tumors. So, and no approved targeted therapy for bladder cancer is available right now. So there is need for different treatment options and different strategies. So researchers are always in search of different targets. Next slide. So what the researchers have done is they are using approved drugs for repurpose use, and they are using single drugs as well as drug combinations. Along with that, they are searching for novel targets. The targets which are already in use with the antibodies or immunotherapies, if they are not effective, there is search for novel targets which are going on. And then for those novel targets, they are designing new small molecules that can affect the pathways which are driven by those novel targets. So these are the three key strategies which researchers all over the world are following for the muscle invasive bladder cancer treatment option, developing new treatment options. Next slide. So researchers like us and worldwide have noticed one thing, that bladder cancer is about 4 times more common in men than in women. Even after if we adjust them for all the collaterals like carcinogenic exposure due to smoking or occupational hazardous exposure to cadmium or heavy metals, still bladder cancer is about 4 times more common. And there is one of the organs just next to bladder, that is prostate, which has androgen receptor as the major player in prostate cancer. So what we thought that androgen receptor, which is just next to the prostate, and they are derived from the same urothelium, both the prostate and bladder. So androgen receptor might play a role in bladder cancer development also. So this androgen receptor is the binding receptor for DHT. DHT is nothing but testosterone, that the androgen reduced from by 5-alpha reductase to dihydrotestosterone. So this dihydrotestosterone, after conversion from testosterone, binds to androgen receptor and activates it. That results in nuclear translocation of androgen receptor, where it binds to different elements like androgen response elements, ARE, and drive transcription of several regulatory factors that finally affect cell proliferation. So when AR expression is high, it is an overdrive. It helps cancer cells to proliferate, and thus the androgen ablation therapy with the help of different drugs like enzalutamide and everything is the primary treatment for prostate cancer. So we thought that androgen receptor might be present in bladder cancer also. And others, researchers all over the world were reporting in patient tissue samples from bladder, that androgen receptor is present. But there are still some researchers which say that it is low, and some researchers who were showing high. So we went on with the research on androgen receptor. Next slide. So we observed that in our patient cohort, androgen receptor expression was higher in invasive bladder cancer tissues. It was present in almost 61.4% of tumors from male bladder cancer patients. And as you can see in the first figure, that invasive bladder cancer cases, the patient tissue samples has very high expression of androgen receptor. Now, to see whether these results can be observed in the bladder cancer cell lines also, we checked in bladder cancer cell lines which range from uroxa, that is the immortalized bladder epithelial cell, normal, from non-muscle invasive bladder cancer cell lines like RT4 to muscle invasive bladder cancer cell lines like TCC, SUP, and UMS3, and we observed the same trend in the cell lines also. AR is highly expressed in MIBC cell lines. You can see. Next slide. So now we know that bladder cancer has AR expression. So the next question was, can the androgen ablation or androgen receptor inhibitors like enzalutamide, can they inhibit the muscle invasive bladder cancer cell growth? So we treated enzalutamide with the DHT treated cells and also enzalutamide in combination with DHT, and we observed that there was inhibition in muscle invasive bladder cancer cells. Moreover, as you can see here, that the androgen in the second figure, in the confocal microscopy figure, you can see that when we give DHT to the cell line, the androgen receptor goes to the nucleus of the cells. So there is a nuclear translocation, clear nuclear translocation, whereas when we give enzalutamide, that nuclear translocation is stopped. So enzalutamide is the androgen receptor inhibitor, which works by blocking the effect of androgens, and it categorically blocks the translocation of AR to the nucleus. So here we were able to see that AR translocation in bladder cancer cell lines was stopped by enzalutamide. So we know that enzalutamide is working in muscle invasive bladder cancer. Next slide. Now, when we saw the enzalutamide IC50 in MIBC cell, it was quite high. It was ranging from 4 micromolar to 10 micromolar, and same goes with the cisplatin, which is high in the 6 micromolar to 12 micromolar range. So this is very toxic. This is the toxic effect of cisplatin. If it is in high concentration, it causes renal toxicity. So to optimize the combination of 2 or more drugs, it is important to generate data with different concentration of both the drugs and do isobologram analysis. And we found that we had a combination index of 0.35 at enzalutamide, lower concentration of enzalutamide of both and cisplatin, both the drugs. At least 3-fold in cisplatin and 2-fold in enzalutamide, these drugs were reduced. And we got around 0.35 value. So if it is a good indicator of whether the drug is an additive or antagonistic or having a synergistic effect. If it is lower than 1, then we can say that, okay, this is an indicative of synergistic action of the drugs, where both the drugs are lower than their IC50s and they are producing similar or an exaggerated effect. So there are several experiments which were followed after that, apoptosis and all those assays to confirm these findings. And interestingly, we saw that the muscle invasive bladder cancer which is highly invasive, this combination was categorically inhibiting the epithelial to mesenchymal transition, invasive behavior of these cell lines. And the EMT markers like E-cadherin, N-cadherin, and all the EMT markers were N-cadherin environment. They were decreased. E-cadherin was increased. So this was indicative of the effect of both the combinations in lower quantities, inhibiting the mesenchymal transition and invasiveness of the muscle invasive bladder cancer cell. Next slide. So this is about the combination of the drugs. Now, if we search for the novel targets, then there are steps which we have to follow apart from the combination treatment. For this, we followed a path, and most of the researchers followed a path wherein they screened molecules that can inhibit the cell growth, and then analyze difference in expression of key genes, oncologic genes, and the next step would be to identify the mechanistic aspect of growth inhibition and validation of the target. So we identified, we screened several molecules, next slide, and found a compound ASR488 during our screening. This is on the next slide. Yeah. So this is the compound ASR488, which could inhibit the MIBC cell growth. And interestingly, ASR488 treatment did not show any toxicity in the normal bladder epithelial cell. So this was very interesting. So we chose this compound and the treated cells for our RNA-seq experiment, and we analyzed over 5,000 key genes. And what we observed was that there was a key gene called CPEB1. Next slide. There was a key gene called CPEB1, which was highly expressed in the treatment. There was around over 3,000 differentially expressed genes. Some of them were upregulated, some of them were downregulated by the treatment. And there are, these are the, as you can see, there are key genes, CPEB1, CYP4, F11, IL11, SFN, SPHK1. These are the genes which were highly upregulated. We confirmed this by at RT-PCR and protein expressions and everything, and we found that CPEB1 was the gene which was highly upregulated. So this CPEB1, next slide. The CPEB1 is a cytoplasmic polyadenylation element binding protein. This is a sequence-specific RNA binding protein which regulates polyadenylation and translation initiation. As you can see here, when during the transcription, when pre-mRNA is formed, there is 5' capping and polyadenylation poly A tail at 3'. This 3' untranscribed region, although it is untranscribed, it doesn't mean that it is not important. Untranscribed region is very important for regulatory purposes. This 3' untranslated region is the section of mRNA that is followed directly after the terminator region. And regulatory region within this 3' untranscribed can influence translation efficiency of a gene and also the stability of mRNA. So this is a very important and key regulatory region in an mRNA. This CPEB1, what it does is it binds to CPE sites in 3' untranscribed regions. These CPEs are nothing but cytoplasmic polyadenylation element sequences. These are uridine-rich sequences, and RNA recognition motifs in CPEB1. As you can see, this is there is a structure of CPEB1 here, where RRM1 and RRM2 sites are shown. These are RNA recognition motifs. These recognition motifs recognize the CPE elements in 3' UTR regions of mRNAs, and they bind there and then promotes elongation of poly A tail. So CPE mediated translation, because it binds to CPE elements in 3' UTR, it mediates translation of control targets, and this is about 10 to 20% of the genome, which is regulated by these cytoplasmic polyadenylation elements. And particularly, these are the transcript which encode cell cycle and cell differentiation regulators. So CPEB1 promotes elongation of this tail and thus regulates translation of several key mRNAs, which are later involved in oncogenic roles also. So we found that our ASR488 was increasing CPE1 expression. Next slide. So now we know that CPE1 is overexpressed in treatment. So what happens when the CPE1 is low? Is the CPE1 expression is low in bladder cancer? So to see that in our patient cohort, the same patient cohort, the same bladder cancer patient cohort, we saw that bladder cancer cells had very drastically low expression of CPV1, and it was correlated with the cancer stages. As the cancer stages progressed, the CPV1 expression was lower. So this was a confirmation of the CPV1 expression in bladder cancer. Now, just as we did confirmation in bladder cancer cells earlier of androgen receptor, we performed RNA, mRNA analysis of CPV1 also. And we saw that in muscle invasive bladder cancer cell lines, CPV1 was drastically low compared to the normal bladder cancer cell. So this was a indication that CPV1 is low in bladder cancer. Next slide. So we now got a lead that CPV1 is low in MIBC, and our treatment of our compound increased its expression. So how the increase in CPV1 regulates cell proliferation in MIBC? To see that, first what we did was we saw what is the binding capacity of ASR488. Does it directly binds, or does it regulate some other protein to finally indirectly regulate the CPV1 expression? So we did some experiments, thermal shift differential scanning fluorometry assays, and we were able to deduce that ASR488 is in fact directly binding to CPV1. The exact site of binding is not known yet, but we are confirmed that there is a direct binding of CPV1 on ASR488 on CPV1, and thus the reason for influencing its expression. Now, to understand how ASR488 works through CPV1 and brings its inhibitory attributes, we analyzed how ASR488 induces cell death and found that pro-apoptotic pathways, here the results are for FACS analysis only, but we did all the pro-apoptotic pathways, and we found that pro-apoptotic pathways were induced. And from the RNA-seq data, we already knew that cell cycle regulatory pathways are affected. So what we did was we analyzed all the cell cycle regulatory markers, and we found that whenever we overexpress CPV1, there is a key regulatory P27 KEAP1 marker which was upregulated in all the cases wherever we overexpress CPV1. This P27, as you might know, is an enzyme inhibitor that is coded by CDK and 1B gene, and it encodes a protein which the cyclin-dependent kinase, CDK, inhibitor protein. So these CDK proteins they control the cell cycle progression at G1. So to see whether the cell cycle is actually getting affected, we did cell cycle analysis, and we saw that G0, G1 phase is actually inhibited, and cell cycle is inhibited at G0, G1 phase. Next slide. Now, to confirm whether CPB1 is regulated cell proliferation is in fact going through P27, we knocked down CPB1 in MIBC, and we saw that even after treatment of ASR488, where P27 KEAP1 expression was also low because of CPB1 knockdown, there was no significant effect on proliferation of the cells. So we confirmed that CPB1 P27 KEAP1 expression was the key. This is the signaling pathway from where ASR488 is acting. Now, where exactly CPV1 binds in P27, which regulatory elements, where in the polyed 3' UTR region is still to know, but we have confirmed the CPV1 overexpression is driving the proliferation, stopping the proliferation in MIBC cells. Next slide. So now we know that the treatment strategies which all over the world for muscle invasive bladder cancer people are following are combination therapies, which one part which we did was cisplatin and enzalutamide, which did synergistic inhibition of MIBC cell growth. This is not the only combination therapies. Researchers all over the world are following different immunotherapies, molecules, as well as there are clinical trials which are going on with cisplatin, enzalutamide, and other drugs like gemcitabine. So there are other combination therapies which are being used and which are in advanced stages of clinical trials in muscle invasive bladder cancer treatment or management. And also there are novel targets which are being searched, like CPV1 in our case, and there is other targets which are being searched, mostly the cell cycle regulatory and DNA damage pathways related targets which are being researched over the research in the research community all over the world for muscle invasive bladder cancer. But right now there is none which is in the advanced stages of clinical trial. They are early stages of clinical trial. Next slide. So this combination, there are some recent development which are of note. Like there is a new version of BCG which we used as an immunotherapy for direct site at the direct site of bladder cancer, superficial bladder cancer. There is VPM 1002, which is a new version which is still in development, but it is in very advanced stages. And there are several combination of immune checkpoint drugs like olaparib and durvalumab. So these are the checkpoint drugs, immune checkpoint drugs, and other combinations also are in use, are in the advanced stages. And recently in December 2019, FDA granted approval for a combination of two immunocheckpoints drugs, the combination only. So people are trying different combination and repurposing different drugs which are already in use to the treatment of bladder cancer. And there has been recently a successful completion of clinical trial, phase 1, which determined the toxicity of cisplatin in combination with enzalutamide and gemcitabine. They actually saw a complete remission of bladder cancer in one of the cases. So it was a successful completion. And there are other trials also which are going on right now in muscle invasive bladder cancer. Next slide. So this is my research team here: Dr. Chandil Damodaran, Dr. Balaji Chandrasekharan, and Dr. Venkatesh Kolaru, Dr. Uttarasaran, which is working, and I want to thank them and thank the organizers as well as the team, and I'm open for questions.
Thank you for your valuable presentation. Now it's time to share the students' question. May I request the audience to unmute yourself to ask questions to the expert. Students or participants are kindly requested to ask questions to the expert. Those who have question, please please unmute yourself and ask your question. Student participants can unmute yourself and ask your question to the expert.
Dr. Tyagi?
Yes.
Thank you for your wonderful presentation. I have a question. As you have shown that CPEB1 is downregulated in various stages of cancer.
Yes.
Did you do any overexpression studies and check the effect?
Yes, we did actually. So we overexpress CPB1, and we found that whenever CPB1 is overexpressed, the MIBC cell lines, the progression of their cancer and cell proliferation itself is decreased. And as you can see in one of my slides, I showed that we overexpress CPB1, and the P27 is also overexpressed in those cell lines in those cases. And as we overexpress CPB1 and P27, there was a direct inhibition of cell cycle at G0, G1 case. So we confirmed this with the overexpression of CPB1. Thanks for
Okay.
asking.
Whether it downregulate the EMT process?
Yes, yes. So
Okay.
whenever CPB1 is overexpressed, the MIBC cell line proliferation is inhibited.
Okay. Thank you.
Any questions from the audience side? Student participants, do you have any queries?
Please feel free to ask some questions. Students?
Dear participants, student participants of first MSc, second MSc, and the third BSc Biotechnology. So we expect your interaction with the chief guest. And Dr. Tyagi sir,
Yes, sir.
I have a question.
Yes, sir.
But the question is very simple. Though the word cancer is known for several long years, why we couldn't find any prominent drug to control it? Because
Yes, that's a very simple question, but a very complex answer to it. Because there are so many, this is a complex disease. There are so many sites of cancers and so many targets which are and pathways are involved that it is difficult to target one thing and get the desired result. So it is difficult to manage the cancer because of its complexity. And there is good progression right now
okay,
in the field.
thank you, sir, thank you. Sir. Participants, any questions from your side? Okay, thank you, sir. Thanks for your valuable presentation. And now let me invite Mrs. P. Geetha ma'am to propose a vote of thanks.
Thank you, Samuel sir.
Thank you, ma'am.
Honorable Principal sir, respected HOD sir, respected Organizing Secretary and Co-Organizing Secretary, most valued invited guests, faculty members, and all the participants. A very good morning, everyone. It's my privilege to propose your vote of thanks on this occasion. First of all, I would like to thank Almighty God for making today's function as a great success. Wholeheartedly, I must thank our principal, Dr. C. Ashok, sir, for your support and guidance for organizing such an event. Thank you, sir. I'm happy to express grateful thanks to our HOD, Dr. M.K. Rajan, sir, who has always popping up us through his motivation and dedication. Thank you, sir. On behalf of our department, I would like to extend my heartiest thanks to our honorable resource person, Dr. Ashish Tyagi. He delivered a wonderful speech about treatment strategy for muscle invasive bladder cancer treatment. We have learned more information from your speech, sir, especially like stages of bladder cancer and superficial stages and the treatment and the radiation plus chemotherapy, and we learn more information about androgen receptors and the indications of CPEB1 expressions. We are inspiring your speech, sir. Thank you, sir. Thank you, sir. Then, my sincere thanks also go out to the members of organizing committee, Dr. D. Prabakaran, our organizing secretary, as well as our visiting faculty of our department, who have provided guidance and constructive comments to make this event possible. Thank you, sir. Extending my thanks to the co-organizing secretaries, Dr. Vijayakumar and Dr. B. Ammal, their constant cooperation and support throughout meeting by their words. Thank you, sir. Thank you, Dr. C. Samuel, sir.
Thank you, ma'am.
I may like to express my sincere thanks to our faculty members, students, and scholars of NJAC, and rest of others who have extended the continued support. Thank you, one and all. Have a great day.
Thank you,
Thank you,
ma'am.
sir.
Thank you so much, ma'am. Thank you so much.
Thank you, madam.
Thank you, sir.
And thank you so much, ma'am. Thank you, everyone, for giving me this opportunity to present.
Thank you, sir.
Thank you so much.
Dr. Ashish, thank you for your valuable time. It's midnight
Thank you.
for you. Yeah, you spent your valuable time for our students. Thank you.
It was my pleasure. Thank you so much.
Thank you very much.
Thank you so much, sir. Thank you so much for your for sparing your valuable time with us. Thank you so much.
Thank you, sir. Thank you so much.
Okay. Thank you.
Bye, sir. Have a nice day.
Yeah.
You too, sir.
Yeah.
Yeah. Day after tomorrow, please join around 10 a.m.
Okay,
The
sir.
coming
Yeah.
Friday. Yes, yes.
I'll be there. Thank you
Yeah.
so much
Thank
for
you
the
very much.
invitation.
Thank you,
Thank
sir.
you.
Thank you so much. Stop.